Welcome to today's webinar on immunization during COVID-19 pandemic, lessons and post-pandemic strategies from Cameroon, Tanzania, and the Gambia, which is brought to you by the BID Learning Network. And my name is Catherine Miawala, your BLN coordinator, and we're so glad that you'll be able to join us, and we look forward to hearing from our panelists for today. Now, before we begin, I'd like to share a few housekeeping guidelines. In the chat box on your right-hand side at the bottom, kindly type in your name and the country where you're connecting from. And in the event that you're with other people, you're sharing the same connection, kindly include the number of other people, not necessarily their names, but the number of other people that are sharing the same connection as you. And we expect that all participants will be muted and the videos disabled. This is to allow the speakers to speak without any interruption, and also not to disturb other people's bandwidth. There will be a question and answer session at the end of the discussion. And we also encourage that you submit any questions along the way in the chat box. These will be logged and answered during the question and answer session. Also, just to let you know that this webinar will be recorded, and the link to the recording as well as the presentation slides will be shared via the BID website. Now, in today's panel discussion, which is the first in the series of discussions, we'll be hearing from different countries as they share their experiences with the impact of the pandemic on immunization programs, and how these countries have leveraged on the lessons learned to mitigate the impact. And so today, in today's panel discussion, which will be led by Professor Josephine Nabukenya from Uganda, we have quite a number of countries that will be sharing their experiences. So our moderator, like I mentioned, is Professor Josephine Nabukenya, who's an Associate Professor of Information Systems and the Chair of the Health Informatics Research Group in the School of Computing and Informatics Technology at Makerere University in Uganda. She's a member of the Uganda eHealth Technical Working Group and the Digital Health and Interoperability Working Group of the Health Data Collaborative. Professor Nabukenya was part of that 10-member core team that developed the Uganda National eHealth Policy and Strategy, and is currently supporting the Ministry of Health with its implementation. She's currently spearheading the development of the eHealth Enterprise Architecture and Interoperability Framework for the health information exchange in Uganda, and the automation of the national registries for the clients, health workers, and health facilities for Uganda. Professor Nabukenya also spearheaded the development and implementation of the doctorate and Masters in Science and Health Informatics programs at Makerere University. She's an ardent member of the ICT societies, including the Association of Computing Machinery, Enterprise Engineering Research Network, and the Group Decision and Negotiation Network. She's also the peer advisor to the BID Learning Network Data Quality and Use Collaborative. I think there'll be a lot that we need to discuss this afternoon, and without much further ado, I'd like to invite the moderator, Professor Josephine Nabukenya, to do the honors and introduce the topic to us, as well as the panelists that we expect to hear from. Professor Nabukenya.
Thank you, Catherine, for the wonderful introduction. I welcome all our participants at the webinar. And before us, we have three panelists. Dr. Drafosa Limo, the program manager for IVD program in Tanzania. She works with the Ministry of Health, Community Development, Gender, Elderly and Children in Tanzania, a position she has held since 2009. Under her leadership, the Tanzania National Immunization Program has performed very well to achieve above 90% for all antigens for the past 5 years. Dr. Limo also serves as Secretary for Interagency Coordinating Committee and the Maternal Newborn and Child Health Technical Working Group under the Sector-Wide Approach Committee. Before assuming her position as IVD Program Manager, she served as the Municipal Medical Officer of Health, Yala Municipal Council. And prior to that, she also served as the Municipal Hospital Director and Coordinator for Care and Treatment for People Living with HIV under the Management and Development for Health Program from 1997 to 2005. She has also served as the General Medical Practitioner from 1991 to 1997, following her internship at the Muhimbili Medical Center in 1990 to 1991. We also have another panelist, Dr. Calvin Tonga, who works in Cameroon and he's a nurse by profession. He has over 10 years experience in public health data management, where he has held various public health portfolios, including vaccination, epidemiological surveillance, and health information management at operational, intermediate, and national levels of the health pyramid in Cameroon. He was the focal point person in public health activities in the Mwako region from 2007 to 2011. He has also served as the head of Poma District Health Office from 2011 to 2012, and he later became the data manager and surveillance focal point at the expanded program on immunization in Lotoro region up to 2016. Dr. Tonga is currently the unit head for planning, monitoring, and evaluation of the EPI Central Technical Group at the Ministry of Public Health in Yaoundé, Cameroon, where he oversees the collection, analysis, organization, consolidation, and dissemination of data. He also provides staff training through workshops, supervision, and monitoring. Dr. Tonga holds a master's degree in public health and a PhD from the University of Douala. Finally, our last panelist is Mr. Mbiye, who has been working in public health since 2000, where his initial focus was on immunization, disease surveillance, and other public health related activities. He became Divisional Vector Control Officer in 2006. Mr. Mbiye became Senior Malaria Control Officer in 2011 and worked in that capacity until 2012. He has also consulted for the STOP program and worked in Nigeria from 2013 to 2014. He was assigned to the EP program in 2015 as the Capacity Building Manager, where he was charged with the responsibility to strengthen the program. Currently, Mr. Mbiye is the Senior Surveillance Officer of the AP and holds a higher national program in public health and a master's in public health entomology. Our three panelists, you're very welcome to our webinar, and we look forward to engaging with you on your experience with managing immunization services during this pandemic that has disturbed the entire world, where we have failed to have control, and we're actually trying our level best to manage what is happening. And that is why we have you this evening or late afternoon to hear from you on how best you're managing in your respective countries, because anyway, immunization has to go on irrespective of the situation, otherwise we lose our children. So Dr. Limo, Dr. Tonga, and Mr. Nie, you're very welcome. We look forward to sharing with you your experiences. And based on that, I will engage each one of you on different activities that you have been trying to deal with while managing the situation at hand. Kathy? Hello?
Yeah, Professor Nabukenya, we're listening.
Okay. I thought I was just speaking to myself.
Sorry, everybody is muted at the moment. You can go ahead, Professor.
Okay, thank you very much.
Professor?
Just a minute.
Okay.
Catherine?
Yes, ma'am.
Catherine?
Yes, I can hear you. Professor?
Yes. Could you kindly get back to me via the WhatsApp? Okay, I will ask either the panelists, to you, Dafrosa, Calvin, Ombie, allow me to invite you to engage the community, our listeners, by using your first names. I hope that is acceptable with you. I will ask, starting with Calvin, could you tell our listeners your experience with any of the challenges that you faced during the national immunization program as a result of this COVID-19 pandemic? I'll give you about 2 minutes to share your experience with more focus on the challenges that you're facing. Calvin?
Thank you, Professor. I think the country, as I'm working at the central level, the country has been faced with challenges in 4 domains. Service delivery first, because there have been restrictions on mass activities and meetings. That the program had to carry out some of these activities, including NIDs, National Immunization Days, that were suspended just 2 days before launching, and also training and other workshops that were planned were cancelled. We also have the personnel involved in immunization activities who are also have been enrolled in the COVID control activities, and there is an increase of workload, and the availability of the personnel for immunization services is being a challenge now. Now, second, in the domain of supply chain, the ban on flight have made it difficult to ship vaccines from manufacturers to the country, thus causing stock tensions at all levels. So this has been a challenge as the country is managing to overcome these difficulties with vaccine availability. Finally, the beginning of we also face challenge related to rumors on COVID-19 vaccine testing that have aggravated vaccine hesitancy in some beneficiaries. And also some parents are reluctant to go to health facilities, especially where COVID cases are being managed for fear of getting contaminated by the disease. So this has resulted in a drop in the turnover of parents at vaccination rendezvous, with subsequent drop in the number of children vaccinated and an increase in the number of missed children. So this is what I can present as the challenges that our immunization program is facing in the context of COVID-19 in our country. Thank you very much.
Oh, Calvin, thank you very much for sharing that experience. But perhaps, Dafrosa, do you have some additions? What is happening in Tanzania? But that is just in case it's totally different from what Calvin just shared.
Thank you, Professor. In addition to what Kevin has said, in Tanzania, we did not implement a lockdown strategy for COVID-19, but what impacted much was the fear for both the health workers and the parents to use the health facilities, especially in the urban setting, where the pandemic was more visible than in rural. And this led to some of the health workers refusing to attend clients because of the fear, and also parents were not eager to come for health facilities because they were afraid of the COVID-19 due to the congestion, especially in the urban population. That is the major challenge which we face. But also there were cancellation, some cancel and health facilities canceled the outreach services because of the fear.
Wow, thank you very much. What an experience. So, Mbie, is it different from how Cameroon and Tanzania are tackling the situation? Any specific challenges you'd like to share with our listeners?
Well, yeah, thank you very much. In addition to what Calvin and the process said, we also experienced some low turnouts, as Calvin has highlighted, but also in addition, because at the beginning some RCH clinics were cancelled because of the fear, and then the director of health services wrote a memo, and then we tried to ensure that they do the exercises with provisions of PPEs. But the major challenge was that PPEs were not adequate for health workers to carry out clinic services when they have to protect themselves. And this has definitely increased the fear among health workers. Yeah. And then also currently due to ban in flights, currently now for the past 2 months, so it has been in out of COVID as well. These are the two things that I wanted to add in addition to what
Catherine, the volume seems to be too low. I didn't hear the last words from BA. Catherine?
Are you able to speak into the mic, closer to the mic, please? Otherwise, this will affect the quality of the recording. We can't hear you.
Oh, you're not hearing me?
Can you speak closer to the mic?
Yeah, okay. Yeah,
that's better. That's better. Could you repeat the last part of what you said?
Yeah, I was just emphasizing that, in addition to the ban in international flights, vaccines we currently experiencing stock out of OPV vaccine. Do you hear me?
By you're breaking. You're breaking. Professor, maybe we could move on to the next, as Bai tries to organize himself on the other end, because I think he's got a problem with the, it's either the network or the equipment he's using. Professor?
Okay. I would be happy to hear from the François any strategies that you could have taken, and from those strategies, what lessons did you have during the implementation of the immunization program to improve service delivery during this pandemic? We could follow from what you just shared as the key challenges that your country faced. Fear of the mothers, especially at congested serving points. How did you manage such fears in order to encourage them to continue coming for immunization services despite such fears and other challenges they could have come across? And two, what kind of lessons can you share with all of us as listeners on how you implemented, how you managed these challenges during this pandemic?
Thank you, Professor. As I said earlier, that in Tanzania we didn't implement the lockdown strategy, but knowing that the services were being impacted through fear of health workers and our parents, we went quickly to the demand creation, addressing the issues of letting the community understand the extent and how they can protect themselves, but to continue using the services for their children accessing the immunization services. So what we did, we team up with the communication group in the Ministry of Health, which we are developing the communication materials, and we went through the social media and the WhatsApp and the SMS to send the correct information to the people so that they understand what the extent of the problem and how they should, what are the conditions they should take, but not running away from the health facility. And in further in that, we use the Zoom meeting to make a connection with all our subnational immunization officers, giving them the correct information, telling them how they should continue providing the services, but observing the preventive measures for COVID-19. But we went further using the e-learning strategy, where we connected all health workers and the immunization managers through the e-learning platform, where we give them the strategies they should use on how they can book their client into the system for those who are using the electronic immunization registry, so that they don't have a congestion at the facility, especially in the urban setting. But for the rural, we encourage them to continue using the services, make sure that they have the hand washing and keeping the distance, but the children need to be vaccinated. And the moral to that, we had also the talk over the radio, over the video, in almost using the local radios to send the information to the community and encouraging them to use the health services, especially vaccination. And we give them a caution that by not utilizing the immunization services, they bring back the outbreak of some of the diseases like measles outbreak. So with that, we found now clients coming back to use the services, observing the prevention, and also the fear of the health workers start going down because now they have the correct information on how they should implement the services without interrupting, but observing the preventive measures. Over.
That's quite interesting. It's just that I wasn't able to figure out the numbers you had before the pandemic and the numbers of mothers that are reporting during the pandemic. over the numbers of the mothers that are reporting after giving them more information or correct information on how to prevent and do away with the fears. Did you manage to identify such numbers? Are the numbers bigger now compared to the numbers you had when they had fears, or the numbers are still more or less the same and you're doing something about getting the numbers better?
When we observe our coverage of month of April and May, we could find that the coverage is going up. So it was that initial when we announced that we have a case now in Tanzania is when the panic went through all the community and the health worker. But when we flood in the information, it didn't take long because we were addressing also on how we should take out the fear to the health workers and community. So they started picking up slowly. But we are still analyzing our data to see where maybe they didn't pick up quickly, but the overall coverage is not much affected with that.
Okay, thank you very much. Calvin, is it different in Cameroon? You seem to have reported a significant number of challenges. How have you managed to take care of them, and what lessons can we learn on how you're managing the situation?
Okay, thank you, Professor. I will start with the vaccines. The program head has been working alongside partners, and advocacy has been done at higher level to obtain authorizations for cargo flight to land in the country and supply vaccines despite the ban on flights in the country. This is how we were able to overcome challenges with vaccine supply, and this is what we keep on doing to make sure that there will not be shortage of vaccine in the supply chain. The other aspect is that of demand. Concerning REMOS, the C4D department of the program has developed a communication plan, including online media, social media, because most of the areas affected by this are urban areas, and most of the beneficiaries are connected on social networks. So we work on sharing the right information, also in traditional medias, including radios, televisions, and newspapers. This is to share the right information to the population and to reassure them on the availability and the safety of vaccines that are being provided by the program. For service delivery, guidelines have been developed by the program and have been validated by the NITAC, and is being disseminated to throughout the health pyramids to give the various strategies to be implemented in order to tackle the challenges relating to COVID-19, the COVID-19 context, including having different ways in the health facilities for those who come for disease and those who come for immunization services, in order to reassure them that there is no risk for being contaminated as you go to the hospital. So these are some strategies we've been implementing to make sure that we cope with the challenge we face with the COVID-19 context. Thank you.
Thank you, Calvin. I don't know if Mbie is back.
Yeah, I'm back.
Okay, what has the Gambia done about the challenges you shared earlier?
Yeah, just to clarify that, like I mentioned earlier on, that we had stock out of OPV in the country, and this has definitely affected coverages. And then what we did together with UNICEF, support from UNICEF, they chartered a flight to bring some of the antigens, but unfortunately OPV was left out because of the distance, and the chartered flight was moving from one country to the other to bring vaccines to the Gambia, and we couldn't get the OPV because of its heat sensitivity to avoid risking it being damaged by heat. But other vaccines, we still have all of them in country. And then the other challenge with regards to health workers, not about to cancel the clinics. We engaged with the Director of Health Services, and then he wrote a memo to all regional directors and also hospital CEOs to ensure that all services are continued, especially reproductive and child health services where immunization is given. And then with clear guidelines ensuring that social distancing are also there. And also some of the services like the Gambia's RCH services integrated with other services, but certain services that are non-essential that we could go do away with. For example, weighing the baby, that would take much time. We ask them to suspend them. And also like somewhere also asked to suspend updating of registers, and they just vaccinate tally and then record in the immunization card and also in the vaccine tally books and then send. And also like visits were also appointments for infants were based on immunization schedule instead of coming on monthly basis. Like for example, if you are not supposed to receive an antigen this particular month, the health workers will advise you not to come until the time you are due for the vaccination. These were some of the strategies that we have also employed. The other thing is like because of rumors about the COVID-19 vaccine testing in the African countries, this has definitely impacted so resulted in some women not coming. But thank God we engaged with the risk communication team of the COVID-19 response, so that in their radio programs, TV programs, they were also integrating immunization services into the panel discussion they have in radios and TVs. So this has definitely increased the turnout. And then during March and April, we had a very, very low turnout. It dropped by almost about 40% especially in Western Region 1 and 2, where the urban areas are, and this is where we are seeing most of the COVID-19 cases. But due to this engagement, we definitely saw an increase in May, which has increased a little bit. But yes, we still have in some of these challenges, and then we are definitely trying to also engage, trying to engage with other partners, and then focus on supportive supervision, trying to ensure that health workers also are closely monitored to ensure that clinics are conducted. Thank you.
Thank you, Mbie. I would like to further clarify on the letters you said you wrote to the human resources, to the health workers to report back to duty or to do their service. Are you actually monitoring to see that they are doing their service, and therefore has the number increased in June with respect to service delivery? Are the health workers reporting to duty and helping out to the mothers? Because maybe the mothers, you've seen the increase in their turn up, but we are not sure that it aligns with the service provision.
Yeah, after the letter was disseminated, circulated to all regions and hospitals, the program also embarked on supportive supervision to monitor the implementation of those guidelines and also recommendations that were written by the Director of Health Services. And according to the reports we received from the different teams that visited various regions, okay, all health facilities were continued immunization services, reproductive and child health services, and then all health workers are going to attend these clinics. And then the only thing that we saw is like some of the guidelines that we highlighted needed some resources which could not be provided by the health facility. For example, provision of hand washing facilities at clinic sites, especially in outreach sites, was somehow observed to be lacking. And also like human resource as well. Like for example, most of these officers also are also engaged in the response to COVID-19. And then like they definitely have to be looking, following different doing contact tracing sometimes. And then the human resource capacity at the immunization level will also be reduced. And this definitely have been observed during the supportive supervisory visits conducted.
Thank you very much for those responses. Now, to the entire team of panelists, I think you've all already indirectly shared with us the impact the pandemic has caused on the immunization coverage and equity. You've indirectly shared with the low numbers during the very first month where the pandemic was really significant. That was Jan, Feb, March, April. You saw very small percentages, but with all the strategies you put in place, we have seen that the numbers, the coverage increased, and so was equity. So I would like to start with you, Calvin. How best, much as the numbers have increased towards end of May and now June, we have just done half the year. We still have the half year to go, and yet we have heard from WHO and other sources that the pandemic is just a start, almost a start. We are seeing the second phase of the pandemic. How do you plan, or what actionable points do you have in place to improve the resilience of the immunization program and also the health system in general? But I would be glad that you share your actionable points, actionable strategies that you have put in place to improve the resilience of this program. We will start with you, Dafronsa.
Thank you, Professor. Knowing that during pandemic we have not really having the clear data, is first to go back to our child registry, getting to know children who have not completed their immunization, who have missed the sessions, and come up with a good number so that if we plan for periodic intensification immunization, we'll know where they are. But for areas where they are using the electronic immunization registry, we have encouraged them to look in their data and see where they are and give them the reminder message through SMS or call them if they have their contact number. But the other thing is improve communication. Use the community setup, community health workers to advocate into the community, to let the community bring back the children to the services. As we observe the areas where there were low coverage, especially for measles, you will see some increasing number of febrile rash. So we cannot say it's an outbreak of measles, but that is an indication that something is coming. And to make sure that we reach the most vulnerable children. For HPV, we understand the majority of HPV children received their vaccination in school. During this time, they were all at home and they could not access their immunization services because the cards were in school. The strategy which we have is to go to school. As we have Tanzania, we have already opened school this week. We encourage the district to support the health workers to do vaccination in school and also to reach the nursery school children to access the vaccination for those who have missed the second dose of measles. Thank you.
Very, very good actionable points that I think the rest of us should learn from, apart from maybe the last one. Like in Uganda, our schools are not yet open, and many other countries, schools will not open until sometime towards the end of the year. But maybe let's hear what Cameroon is saying. Calvin, what are those actionable points you're putting in place to foster resilience of the immunization program and the health system in general?
Thank you. As I said, first aspect is high-level advocacy for the government to have a look on the health issues, and we had letters written by the Minister of Public Health sent to the regional delegates in the 10 regions to make sure immunization services continue. We also have the President of the Republic in his address to the nation concerning the COVID issue, who encouraged the population to continue to respect their vaccination rendezvous. These are some examples of the high-level advocacy that is being done to make sure that vaccination activities do not drop completely. Now, we came up, as I told you, with guidelines on how to maintain the vaccination activities in the context of COVID. And also the country is working toward raising fundings in order to carry out community activities, catch-up activities like PRIs. And we also gave guidelines on how to organize this periodical immunization, routine immunization, intensification of routine immunization activities while respecting the prevention of infectious diseases, that is barriers and distanciation measures that are to be respected. The other thing is the redesign of the communication we do on vaccination to take into account the COVID context and to send positive message to parents to tell them that there is no risk going to immunization sessions because we have already taken all measures to make sure the disease is not spread during these activities. So these are some measures that we also have the training of immunization health workers on the prevention of infectious diseases during vaccination and while building their capacities on vaccination in practice. So these are some activities that have been planned and have started to be implemented in the country. And we think by so doing, we'll maintain, at least we'll maintain the immunization performances at the level we got in 2019 and prevent from a significant drop. Thank you.
Thank you, Calvin. The Gambia, are you doing anything different from what Cameroon and Tanzania have shared with us? Maybe give us the most burning ones, 2 to 3 of them, that Gambia is planning to do differently.
Hello. Yeah, actually, Gambia is we also trying to cope with the situation, and then one of the things that we are doing now is to integrate, for example, because surveillance also is affected in general, and then we want to integrate also COVID-19 activities together with other VPD surveillance, and then try to ensure that like these people also they identify cases in the communities and also try to report them as soon as possible. We're also trying to engage vigorous community engagement and social mobilization, because we have what we call village support groups that are in the communities, and then we want to engage them so that they can be doing house-to-house social mobilization in the communities, and other partners also like Red Cross also. And then also conduct research, and so to have better understanding of why mothers are also not turning out. We are all what we are doing is based on assumptions, and there is no research conducted in during this period to find out what has been influencing this low turnout. I know one of them is the fear of the COVID-19 and then also the lockdown. But in addition to that, also we definitely want to see what actually is preventing some of these mothers to not to come to the clinics. And we also have to engage the clinicians on missed opportunities for vaccination, so that they can detect at the OPDs and refer to the immunization tables for all defaulters that are reporting if they are sick. Yeah, these are some of the things that we definitely plan. And in addition to that, also we also know that like these rumors are definitely affecting So we are also about to with UNICEF, engage with UNICEF to develop some short videos and messages on the importance of immunization to be shared on social media, because we've realized that social media, especially these WhatsApp groups, it's a very, very powerful tool, and then a lot of wrong informations are being sent there, and then we definitely want to target some of these groups to ensure that like correct information on immunization services are also shared there. So these are some of the things that we have in plan as well.
Thank you very much, Gambia. We have really learned a lot about how to manage the immunization program and the health system generally during this pandemic, but perhaps it would be good that each one of you can spare half a minute to tell us on how best we can, how best we could minimize the impact of this pandemic in our different countries. I mean, everybody has done their best across the globe, but what do you think each one of you could be done differently to minimize the impact of this pandemic, especially on the program, the immunization program, and the health system at large? Just in half a minute, I will ask you the Frosa.
Thank you, Professor. The big thing which I can say is the data used for action. This is very important to tell us what is happening at the service delivery, what is happening in the supply chain, and what is happening in the communication. The second thing is effective and efficient communication to the health workers and to the community, especially the parents and the caretakers. And the third, good leadership and management. Thank you.
Wow, that is quite interesting. The Gambia, are yours totally different from what Tanzania is planning to do?
Yeah, in addition to data for action, data used for action, we also planning to identify defaulters and follow them up, and then also try to see whether we can conduct a small catch-up campaign for routine services. For example, those children that defaulted, if we identify them, engage health workers at their various health facilities, and then go to the communities and call out these people so that they get them vaccinated in the communities. These are some of the things that we are definitely trying to work on. Thank you.
Okay, thank you, the Gambia. Calvin, it must be totally different from what Tanzania and Gambia are planning to do to minimize. In half a minute.
Just about the context, the environment, I would have said in managing the outbreak may be for the disease that can be contagious is to manage the cases far from where immunization services are being provided. That is one thing. And the other thing is also intensifying community activities to make the services closer to the beneficiaries and sensitize them on where they can get the services and go for their rendezvous. Thank you.
Thank you very much, Tanzania, Cameroon, and the Gambia. I now would like to open up the discussion to our listeners. We have had very interesting experiences, challenges, strategies, solutions, and actionable points of how to manage the entire situation, including how to minimize this pandemic not to affect our immunization program services. So now I would like to open up the discussion to the rest of the listeners. Catherine, how would you like us to go about this?
Thank you very much, Professor. We had asked everybody who had questions to type them in the chat box. Right now I've seen one, but I will open up, like you have mentioned, for the discussions. What could happen is people could just lift their hand if they're not typing any questions, then we can pick them up from there. May I read out the first, as people are thinking about raising their hand, can I read out the first question that has come out?
Yes, please proceed, Kathy.
Thank you. So this question is from Dr. Khalid Abubakar, and he's saying that all the presenters did well in sharing with us the challenges and the plans to close the gaps identified. He wants to hear any experience regarding surveillance of polio and any other priority diseases in aspect of active search, investigation, and verification. Are we able to answer that particular question?
Yeah, hello. I can come in that place.
Excellent.
With regards to the Gambia, we realized that like the pandemic has definitely impacted AFP surveillance, but measles cases suspected cases have been reported. What we are planning with WHO country office now is to engage with surveillance officers, because they are mostly busy in this contact tracing and also quarantining of these suspected cases. So we want to definitely have an activity called active case search, whereby they will definitely go around spread into the country and communities, visit traditional healers, try to see whether they are seeing AFP cases. So because right now, as we're speaking, our non-polio AFP rate report is as low as 1.2, which is very, very low. We're definitely trying to ensure that like this is boosted up to ensure that like cases that were not being reported, we definitely bring them out. So the other challenge also is like we have cases lined up that were reported, but because our reference laboratory is in Senegal, and then these border closures and lockdowns in both Gambia and Senegal, we couldn't transport these samples to Dakar for testing. These are some of the challenges that we are just facing right now. But we are definitely working with WHO country office to ensure that like we actively search for cases, and this is definitely going to start in the next coming weeks, so that they can look for cases in their respective catchment areas. Thank you.
Can I add something from Cameroon?
Yes, please.
In Cameroon, our surveillance system is such that we almost have all our infrastructures in the country except for confirmation of polio cases. So everything has been moving normally, and we've not observed a particular drop in the surveillance performances. And I think this is also thanks to the mutualization of the personnel, because one of the challenges that we had with COVID is that the personnel working for the EPI were enrolled in COVID control activities, but these surveillance personnel now were carrying out both activities, and we also have rapid intervention teams that have been set in place in the COVID context, and they are also involved in case investigation anywhere we have high risk for COVID. And this mutualization of resources has had as a result that we have not faced a drop in surveillance performances in the country. So I think this is one of the lessons learned, that if we really mutualize the resources, if the actors are involved in both diseases, especially as it is surveillance, and the same as we do surveillance of the active search of vaccine preventable disease, you do active search of COVID cases. COVID may rather be an opportunity to carry out active search in the community, in addition of the other community health workers who were already working for active search of vaccine preventable disease in their respective community. Thank you.
Yeah. Thank you very much, Calvin. Dr. Defrosa, did you want to add something?
Yes, Prophet. From Tanzania, as I said, we continue with our normal delivery of services, so surveillance also continuing. What we did, we just communicated with the WHO, who were working at home. So the specimen continued to be collected from the community to the national level. The challenge we have is the national lab for measles, rubella was not functioning because all staffs were engaged in testing for COVID-19. And the specimen to go to the reference lab in Entebbe was also interrupted because of the transportation, but it continues to move on. The surveillance officers who are working on the immunization for VDP, they were also engaged in COVID. So it was not much interrupted because they could pick the cases and also could take the specimen and bring it to the national level. And this, it might be interrupted a bit in areas where they couldn't reach in normal if the health facilities were not attending clients, especially in urban situation, but in the rural, the services and surveillance continued well. Hello?
Yes. Yes, we can hear you, Doctor. Dr. Limo, we can hear you.
Okay, thank you. And also I saw the question from Joseph asking about whether we use the Tanzania Immunization Registry to mitigate the impact of COVID-19. As I said in my presentation earlier, that the immunization registry was also used to map up the children who were missed during routine, and they could send SMS to remind them to come for health facility. For the district which are fully implementing the TIMRI services, they also use that immunization registry to queue their children to avoid congestion. They could book them in time spacing, and they could not congest them in one time. Also, they could map how many they should come for certain vaccination, like measles, rubella vaccination, group them in a number which they can manage. So to answer that, it was yes, used, and it was very effective, and that is what we want to scale up countrywide to make sure that it will help us to map up. And also it's a good system which you can know how many children have defaulted from immunization services. Thank you, over.
Thank you so much. Madam Moderator, there is a hand from Suleiman Itemaso from Nigeria. We shall unmute him so that he can ask his question.
Okay, yes, can we let him ask?
Okay, thank you, everyone. Thanks to the panelists. I've been hearing talks about getting more children vaccinated, particularly those that defaulted. But I want to know about I'm interested in the plans for protecting the healthcare workers, because I know that there is a challenge with that category of people in the workforce. So what are we doing to protect them, even when people are coming to the facilities? Secondly, I'm interested in knowing the Tanzanian experience with the implementation of planned activities pre-COVID-19, particularly when there was, if I heard correctly, that they didn't implement lockdown. So how did they continue with their planned activities even during the pandemic? And I also had some, particularly Gambia, I think Kelvin also mentioned it, from Cameroon, about a rumor about COVID-19 vaccine. I don't know if it played out that way in Tanzania too, and how the tried to mitigate that challenge. So the question on the implementation of planned activities in Tanzania, I'm asking, I want to know, because particularly most of the things I'm hearing from the panelists is as if they are speculative. It's clear that people defaulted in vaccination, but we are not very sure. I know that Mbai spoke about stock out of polio, OPV. So we don't know if some other factors were responsible for the defaulting of the people that are supposed to access the services. So just to get some clarification on that, why can we put our fingers on some reasons why people are not coming, particularly? Thank you. Over.
Okay, can I come in for Cameroon?
Sure.
Okay,
Go ahead.
Suleiman, I'm very happy to hear from you. It's been long. Concerning our country, the reasons for defaulters, I raised up some reasons. One of these reasons is that some parents were scared with going in their normal health facility where they usually have their children vaccinated, because COVID cases were managed in this facility, and they were afraid like they may go there and be contaminated with COVID. This is one reason that has been presented, and so they didn't go to their rendezvous. This is one reason. Now, another reason also for these defaulters is that some vaccination sessions couldn't be organized. In some other health facilities, there are places where the vaccination sessions could not be organized due to activities relating to COVID-19 management. And concerning the implementation of the plan or the speculation, for now, we can't give clear figures on the gaps that are due to COVID, because of completeness of data, we don't have data completeness that can enable us to give clear data, but we know there is a drop. COVID struck the country at the end of the month of March, so the impact started to be felt for the month of April and May, but we don't give clear figures, because for these 2 months we have not got to about 95% of data completeness. Now for the plan, as I also said, for our action plan, the action plan that we designed at the beginning of the annual work plan that we designed, we could not really implement it as from March. There are some activities that, due to the ban on mass activities like the NIDs that we were supposed to carry out at the end of March, we could not. They were suspended 2 days ahead of the D-Day, and also response campaign to CVDPV in the country were cancelled too. So all these there are some activities that were cancelled like that, and we now came up with a mitigation plan. There are activities that we've developed. There are strategies that we've developed to mitigate the impact of COVID, including these community activities that are to be carried out in urban, in cities that recorded the highest number of COVID cases, and where people are scared with going to some specific health facilities. So there is a plan on that, and resources are being mobilized towards implementing these activities to improve on immunization coverage and mitigate the drop in immunization due to COVID. Also, we are preparing to review our annual work plan, and this will give room for taking into account the change in the context due to COVID-19, and including the specific activities in the annual work plan, so that it is being followed up across the 6 months that remain in the year. So these are some answers that I can give to the question from Suleiman. Thank you.
Thank you very much.
But I think it would be good also Tanzania to answer on that question.
Yes.
Dr. Foster?
Thank you very much, Sleman, for the question. To start with on how we were protecting our health workers. As we all know, we have the standard protection guideline for COVID-19, which happened globally, using masks, hand washing, sanitizers, distancing. As I said in my presentation, that the impact of COVID was more visible in urban situations rather than rural. And the concentration and the fear was more on the hospitals, where client or parents will know that they know the COVID patients will be admitted there. Immunization services is provided in primary health facilities, dispensaries, health posts, and the community. So the majority, so the figure which I said was not much affected is not a speculation, is how the service deliveries are provided. Fear was there, yes, for health workers and the parents, yes, and that is where the government went viral, giving the information on how they should use the protective gears and the protective steps to avoid them to contact COVID-19. So it was directed to how parents they should protect themselves and how health workers can protect themselves. The second thing, how did we continue with our activities? As I said, we didn't lock down. What we didn't do meetings. We switched to visual meetings. Like what I said, we used the Zoom meeting, we used the WebEx meeting, also we use the e-learning platform. So that is how we conducted our meeting. But in the office where we were doing our activities and normal, what we just did is spacing ourselves. If we are 5 or 6 into the office, you just space to be two, they can work it today, the other one they can work it the next 2 days. So all this is observing the protective measures which was given, and trying to get fear down. Communication, we had a call center which was established at national level, which was sending messages through WhatsApp, through emails, through all social medias to make sure that people understand and how they can protect themselves. So this is, we might not believe, but that is what has happened in Tanzania. Thank you.
Thank you, Tanzania. You just said that most of the fear was within what we would call the urban centers. But then we would like to understand how you were creating you were addressing creation of this demand of immunization services for mothers in the hard to reach areas. Those mothers who do not have access to the communication channels you talked about, and or the access to information, the different information access sources you talked about. I would be happy if also Calvin and Mbie briefly told us how they were reaching those villages in the rural areas. But first, let's start with Tanzania.
Thank you, Professor. To alleviate that fear, we have printed leaflets which we are going throughout to the community. We use, if you know, the bajajis which they are moving, we give them these leaflets. Whenever they have a passenger, they educate them. So it's like we educated some peer groups, social groups to make sure the information go down, even for those who they cannot see the television or they cannot hear the radio. But the other thing, as I said, we conducted the Zoom meeting with our sub-national levels to bring back the outreach services while observing the distancing and the crowding. That is how we give them that they shouldn't stop the outreach services, they should continue, but we tell them the steps to do. But the other thing for those who are in hard to reach, the regional commissioners, the RMOs, the district medical officers, they are part and parcel to make sure that these preventive were implemented while observing not to increase the spreading of COVID-19. So that is, we use the government structure from national, sub-national to the community level leaders to make sure that the information and the protection SOPs are followed.
Calvin, did you do it differently, or are you doing it differently to reach out to the rural mothers who also from the Gambia?
In Cameroon, as in Tanzania, COVID-19 has not been that challenging in rural areas, although these had to reach communities have existed and still exist now. We have developed specific strategies to get to them. First of all, we have some areas that are hard to reach due to insecurity. For example, in 2 regions or 3 regions in the country where we have some social upheavals or Boko Haram that have caused some insecurity and that has caused insecurity. So we've been working with the partners of the program to target and reach to this population. So we've organized intensification of routine immunization, targeting them. This is for immunization, and for the past 2 months, we've organized 3 rounds of these activities. And this is about the question from Suleiman. Our personnel were equipped with masks and hand sanitizers, and also the beneficiaries had to respect distancing as per the organization of the vaccination sites anywhere the teams were going. Because we took also into consideration that this activity should not be an occasion for spreading the virus. So we vaccinated in these regions for the past 2 months in 3 rounds, and we vaccinated quite a lot of children. And the normal strategies, the routine strategy like outreach activities and mobile vaccination activities are also being carried out where they were planned without much problem. So where we really have problems with COVID is really in town, and we intensify these communication activities to make sure that parents finally get back to their vaccination rendezvous with their children. Thank you.
Okay, Gambia, are you handling it differently? In the
we have the first rumor that came out in the Gambia was like COVID-19 vaccination is being conducted in schools, and then before the schools were closed, parents started going to the schools and get their children out of the school. But we have communication officers in all the regions who took it upon themselves to ensure that like this rumor is dispelled. And then they use all available avenue at RCA clinics, radio, community radios, to try to give them the information, the correct information about what is happening in terms of before a vaccine happens. Even for this COVID-19, it takes a period. It doesn't come like that. And then we will not give vaccines whenever or when it is not tested and approved by WHO. These are some of the things that we have definitely been experiencing. And in addition to the protection of the health workers, as Suleiman questioned earlier on, we are integrating the COVID-19 response to routine immunization as well as VPD surveillance. And then like all the preventive measures that have been taken in COVID-19 response are also carried out if you are also conducting immunization or any other surveillance activity that you are doing. And these are the same people that are definitely doing the response as well as immunization. Some of them And clinicians also, like we also have reproductive and child maternal and neonatal health services, and adolescent services, RMNK. They also engage in intensive community sensitizations in the communities and also using radio programs and all those things. So the program also at this level at API also, as I alluded earlier, we are also working on videos and also audio messages to be shared with media personnel and also shared through WhatsApp platforms. Risk communication, as we have a risk communication team, and anytime we hear a rumor about immunization, we engage the risk communication team of the COVID-19 response to ensure that like those rumors are dispelled during their radio programs and also TV programs as well. So these are some of the things that we have definitely been doing to try to tackle some of these issues. Majority, we are seeing majority of the cases in the urban areas, but also rumors also are spread in the rural areas as well. Even though the turnout in immunization services is higher in the rural areas, but there are also some pockets of people who are definitely not being targeted to ensure that like they definitely come out to the clinics and ensure they receive their vaccines. So this health promotion officers in regions are definitely doing intensive sensitization, and not only them, because we also have partners that are working in the communities, like the Red Cross, IOM are also working in the communities, and they are all supporting in UNFPA are also supporting in this exercises. So definitely we are trying to ensure that like everybody across the country is getting the right information with regards to immunization services, and then rumors that come out are definitely taken care of by the risk communication committee of the COVID-19 response, and they are addressing every aspect, either COVID-19 routine services or whatever rumor that they hear that we anticipate to affect routine immunization, routine services, routine health services will be dealt with. Thank you.
Oh, wow. Thank you, the Gambia. That is quite a big experience on how you're handling the situation, especially in the hard-to-reach areas. I would like, this conversation has been very interesting. It's quite engaging. It's full of significant
Professor, are you still there? Have you, Professor?
Yes, hello.
Okay.
There's another meeting that should have started at 6, so they were trying to reach me. Sorry about that. It has been very engaging and lots of lessons learned from the 3 countries. And I think even the speakers, the listeners, as they kept asking questions, more and more lessons were shared, and we have learned a lot from this engagement. Given the time that we started, I think we have used exactly an hour, putting in mind that we had to wait for more listeners and myself to settle in. I apologize for the delay at the beginning, but I would like to wind up the meeting by giving an applause to our panelists, Dr. Limo, Dr. Tonga, and Ms. Tambie. You have done a great job to share your experiences in the 3 countries, especially how you are managing the immunization program to make sure that it continues to, it perseveres through the pandemic. I think most of us have learned, especially on how to make sure that the program remains resilient, irrespective of the situation of the pandemic. I am especially impressed by how you're reaching out to the hard-to-reach communities, how you're demystifying the rumors and making sure that the mothers still come for the immunization services. I'm also happy to hear how you're managing the health workers and supporting their fears as well, but to continue to serve the mothers. I think that is very, very impressive. I'm hoping that many other countries who have listened in can practice this because a country like Tanzania that did not go on lockdown, I think you have done very well to manage this kind of situation. In other words, we were trying to understand or appreciate what happened to a setting that went through the lockdown and another two settings that went through the lockdown and another setting that did not lock down. You can see that almost the same strategies were used to handle the different challenges that both the health workers and the mothers did face. I'm glad to hear that so many things have been done by the different ministries of health, by the different respective governments in the three countries. I'm certain that we listeners have learned a lot, especially on the actionable points on how to deal with the immunization program, making sure that it still remains resilient despite the pandemic. So I would like to extend my sincere gratitude to the three panelists, Dr. Limo, if you're still there, Dr. Tonga, if you're still there, and Dr. Mbie. And I would like to extend again my gratitude to all the listeners, having over 40 people sit for an hour and listen in to share experiences. This has been a very engaging group. Thank you very much. And to our colleagues, Path, you have done a very good job to host us. Thank you very much. Catherine, unless you have something to say, I would like to conclude my moderation at that point. Catherine?
Thank you so much, Professor. And, just to echo your words, would like to extend our gratitude to the panelists, all the panelists, and particularly you for driving the discussion this afternoon. It was really engaging. And also just to thank the listeners out there for joining us today. Like I mentioned before, this is just the first in the series. We expect to engage more countries in the forthcoming weeks, and we'll get to hear the experiences both at national and subnational levels on how they're dealing with the COVID-19 impacts on the immunization programs. So this doesn't stop here. Please, if you have any further questions for our panelists today, feel free to engage with us on those different platforms that are showing on your screens, and particularly the BID Initiative Google Groups. I'm sure the panelists will be more than happy to respond to your questions. And also just to let you know that this webinar has been recorded, and that will share this, the recording and the slides very soon. So thank you very, very much. Madam Moderator, thank you so much. And to the panelists, thank you very, very much. Until next week, Thursday, bye-bye.
All right, thank you.
Bye.
Thank you.
Bye.
Thank you very much.
Everybody.
Bye.
Bye.
Goodbye, everybody. Goodbye, Catherine, Professor Nabukenya. Thank you very much. Goodbye. Suleiman.